Excellence in healthcare education and delivery has been the hallmark of our institution since its founding in 1911. Today, we will dive into an important neurological condition, the tethered cord syndrome affecting the lumbosacral spine. By the end of this presentation, you will be equipped to effectively ask key historical questions related to lumbar spine issues, understand and suspect a tethered cord patient, and know how to confirm the diagnosis. Beyond the tethered cord, our learning objectives encompass a wide range of topics pertaining to the lumbosacral spine. We will reconsider the likelihood of a patient being a malingerer and gain a comprehensive understanding of the diverse pain generators in the lumbar spine region. When taking a patient's history, it is crucial to follow a structured approach. Begin by obtaining a traditional history, covering the onset of symptoms, the mechanism of injury, if any, the location of pain, and the pain level, which can be assessed using tools such as the visual or verbal analog scale or the numerical rating scale. Additionally, inquire about factors that exacerbate or provide remission from the pain, and consider incorporating disability or quality of life scales or scores. Certain key historical questions can provide valuable insights into potential lumbar spine pathologies, including tethered cord syndrome. Be sure to ask about the Valsalva effect, which can exacerbate symptoms. Inquire about radiating pain, numbness, or tingling anywhere in the body, as these can be indicative of nerve involvement. Explore any instances of tripping or stumbling, as well as clicking or popping sensations in the lumbosacral region or a sense of translation. Additionally, determine whether the patient experiences an increase in symptoms when walking uphill or up a ramp, and whether the pain is worse in the morning upon waking or in the evening. Now, let's delve into the specifics of tethered cord syndrome. This condition is characterized by an abnormal positioning of the conus medullaris, the distal end of the spinal cord. Typically, the conus medullaris should end at the L1 vertebral level or the L1-2 disc space. It's important to note that when referring to levels like L1-2, we are referring to the disc space between the L1 and L2 vertebrae, not the vertebral levels themselves. This distinction is crucial for accurate anatomical understanding. On imaging reports, the level of the conus medullaris may be described in various ways. The report may state that the conus medullaris ends at the L1 vertebral level or higher, or it may specify the disc space, such as L1-2, L2-3, L3-4, and so on. If the imaging report does not explicitly mention the level of the conus medullaris, it is essential to review the images yourself. Both T1 and T2 weighted images in the mid-sagittal view should reveal the location of the conus medullaris. As you develop a working relationship with radiologists, you can request that they consistently include the conus level in their reports to facilitate your diagnostic process. It is important to note that radiologists will not make the definitive diagnosis of a tethered cord. Their role is to report the anatomical findings observed on the images. As the treating physician, it is your responsibility to interpret these findings and make the diagnostic call for a tethered cord syndrome. The presentation of tethered cord syndrome can be subtle and easily overlooked. Patients may experience long-standing back and leg pain without a definitive diagnosis, making it imperative to consider this condition in such cases. The clinical presentation of tethered cord syndrome can vary widely. According to a study by Elawati et al. In Pediatric Neurosurgery in 2012, common symptoms include abnormal spinal curvature, 61.7%, gait abnormalities, 61.7%, limb weakness, 55.8%, urologic complaints, 32.3%, pain in the back and legs, 20.5%, and numbness and paresthesia, 17.6%. Some patients with tethered cord syndrome may experience changes in urodynamics, or the function of the urinary system. Woods et al. In the Journal of Neurosurgery Spine in 2010 highlighted this aspect. Additionally, Yamada et al. In Neurologic Research in 2004 noted that incontinence can quickly become irreversible if left untreated. Flexion movements can also aggravate the symptoms of a tethered cord, as reported by Valentini et al. In Neurological Sciences in 2011. In children, tethered cord syndrome can manifest as worsening scoliosis, lower extremity weakness, and changes in urodynamics, such as bladder control, increased bladder volume, and sphincter control issues, according to Yamada et al. In Neurologic Research in 2004. Other authors, like Elawati et al. In Pediatric Neurosurgery in 2012, note a broad range of neurologic and orthopedic symptoms affecting the upper and lower extremities, pain, and urological dysfunction. In cases where a tethered cord is suspected or when patients are not improving with conservative treatment, it is crucial to order MR scans for further evaluation. Imaging studies may reveal findings associated with tethered cord syndrome, such as a shortened filum terminale or the presence of a lipoma, as reported by Yamada et al. In Neurologic Research in 2004. In pediatric cases, a conus below the L1-2 level and a thickened phylum of greater than 2 mm have been defined as indicative of a tethered cord. Ailawadi et al., Pediatric Neurosurgery, 2012. Tethered cord syndrome can also contribute to the development of Chiari malformation type I, a condition characterized by structural defects in the cerebellum. Valentini et al. In Neurological Sciences in 2011 highlighted this association. In cases where a tethered cord is confirmed and the patient exhibits symptoms suggestive of a Chiari malformation, it may be necessary to order a brain MRI to rule out this condition. In a study by Valentini et al. In Neurological Sciences in 2011, 110 cases underwent neural axis MRI. The conus level was found to be at L2-3 in 55 cases, L4 in 41 cases, and L5 or lower in 14 cases. Interestingly, 100% of the patients were symptomatic, and 74% demonstrated progressive deterioration during the preoperative period. The mean time from the onset of symptoms to surgical intervention was 5 years. Palmer et al. In the Journal of Urology in 1998 evaluated 20 children with tethered cord syndrome for subclinical bladder dysfunction, despite the patients presenting with non-urologic symptoms such as worsening scoliosis and lower extremity weakness. Urodynamic testing was performed 1 week prior to surgery and 6 months postoperatively. Remarkably, 15 out of the 20 children demonstrated improved urodynamics following surgical intervention. In summary, your tethered cord patients will typically be individuals with long-standing complaints who have not responded to multiple forms of conservative care. It is essential to review previous imaging yourself, if available, as many physicians and radiologists may miss or fail to note the level of the conus medullaris. To reiterate, radiologists will merely report the level of the conus medullaris on imaging studies. They will not make the definitive diagnosis of a tethered cord syndrome. This diagnostic responsibility lies with the ordering physician, based on the clinical presentation and imaging findings. As we conclude, remember that you will inevitably encounter patients with tethered cord syndrome in your practice. Be vigilant in considering this diagnosis, especially in cases with long-standing complaints and failed conservative treatment. Additionally, inquire about symptoms suggestive of Chiari malformation, as these two conditions can be associated. If you don't actively consider and look for these conditions, you may miss them entirely. The key is to maintain a high index of suspicion and conduct a thorough evaluation.